So, a very good evening to everyone who has joined in today. And we have a very interesting topic today. And anaphylaxis is much more commoner in clinical practice than we actually think. And I hope all the talks till now have been quite interesting. We are less than 2 months away from the physical conference. And uh, Nandana ma'am will be moderating the session on anaphylaxis in the physical conference too. So, in case you have some burning questions that you are left to ask today, she would possibly be uh, taking them in the session. And in case we would love if you would ask a lot of questions today so that it makes it easier for her to form a good set of panel cases to discuss. To chair the session today, we have Dr. Vishwanath. Sir is a senior clinical immunologist and rheumatologist at Trivandrum and Thiruvananthapuram, as they say it now. And sir is very unique as an allergist because he runs a center where there's a pulmonologist, a pediatrician, an immunologist, and a dermatologist who sit together and manage allergy cases together. So possibly he would have quite a lot of insights for him to give on the topic of anaphylaxis. Anaphylaxis is quite like an orphan disease in India because the drug of choice is not available as it should, possibly for its management. And Vishad sir, you can possibly take over from here, introduce ma'am, and then we'll.
Thank you, Kunal. It gives me great pleasure to be part of this conference. So, as Kunal said, anaphylaxis is something which is there in no man's land, much like much of the allergy is there in no man's land. Everybody knows a bit of it, but a comprehensive approach is what is probably required in most cases. So, anaphylaxis, is a very life-threatening disease. And it's a condition where there is huge gaps in our knowledge in with respect to the management. And as Kunal said, it's a situation where a lot of limitations are there regarding the lack of awareness, timely recognition, appropriate usage of adrenaline. So I think this will be a very interesting session. And to chair this session, to conduct this session, we have Dr. Nandana Bala. Madam is a consultant pediatrician and allergy asthma specialist at Rainbow Children's Hospital and Prudent Health Specialty Clinics at Bangalore. She's an invited faculty of national, international allergy asthma conferences, and she's also a faculty of allergy and asthma conferences like courses like AACA, AAIC, etc. And she's a contributor to national protocols, modules, and textbooks in the field of allergy. We are grateful to have you here, madam. I request you to kindly take over.
Thank you. Thank you so much, Dr. Vishwanath, for that kind introduction. And it is my honor that you are here to chair this session. And so that, I'm very happy about that. And Dr. Kunal, thank you so much for inviting me to do this talk. As you know, as Dr. Kunal knows, it is one of my something I'm very deeply passionate about, the topic of anaphylaxis, because I think a lot of work needs to be done in our country. Dr. Kunal, can I start my screen share?
Yes, ma'am, you can, you can.
Yeah, thank you.
The screen is all yours for the next 50 minutes.
Yeah, thank you. I think you should be able to see my screen.
Yes, we can.
Okay, all right. Yeah, okay. And you can hear me clearly, right?
Yes, ma'am.
Okay, thank you. So I will, kind of give a broad overview of anaphylaxis, but stressing mainly about the practical issues and management issues rather than theory aspects. So I just want, those of you who have any personal experience of anaphylaxis to, kind of put up on the chat box so that I kind of know how you have been dealing with it, or those of you who are used to treating anaphylaxis. Also, I just want you to put it up on the chat box. I just realized my name is incorrect on the screen, so please ignore that. Dr. Kunal, I'm just struggling to go to the chat box, but yeah. Okay, I finally got there. So, any of you who've had to treat anaphylaxis? Okay, so that's interesting. So normally when I am doing this talk, I have a lot of people who've either had personal experience or who certainly have had some difficulties while they were treating anaphylaxis. So we will go through some of the basics also, so that you're all quite confident when you actually manage this. Okay, all right. So um, yeah. So I just want you also to think about any sudden catastrophic events that happen in medicine. Okay. Anaphylaxis is obviously one of them. So there are so many others, like let's say a cardiac arrest or a stroke, where a patient is absolutely well until few seconds ago. And suddenly, all of a sudden, they are critically unwell and they could die if you don't intervene. Okay. Now, the thing about anaphylaxis is it's one of those conditions where if you intervene on time correctly, you can actually make such a big difference to this patient's life, and they can have beautifully intact survival. And a patient who was looking like they're almost dying few minutes ago uh, becomes completely well. Okay, and I think there's very few conditions in medicine where we can claim we can have these kind of results. So it's absolutely crucial that we learn to identify this promptly and treat it promptly. And the other is also true. So if you don't recognize it promptly and you don't treat it, the patient can die. And that is the importance of knowing the precise management of anaphylaxis. So, the commonest cause of fatal anaphylaxis. So, in fact, I would just, Dr. Kunal, I just want you to monitor the chat box for me to stop me from going to and fro. So, what do you all think is the commonest cause of fatal anaphylaxis? I'm not talking just anaphylaxis, I'm talking fatal anaphylaxis. Any comments on the chat box, Dr. Kunal? Let me know when
Not
there is.
till now, yeah, ma'am.
Okay.
I think the audience will need a little more prodding for them to be more interested.
Yes. Okay. Okay. So it's interesting. So again, there are many causes of anaphylaxis, which we will now go through, but the commonest cause of fatal anaphylaxis is actually drugs. Okay, and we in India have to rely on data from elsewhere, from the rest of the world, because unfortunately we don't have our own monitoring system, our own registry. And that is a big issue for us because we don't know what's happening here. Okay. And the other thing I just wanted to kind of highlight to all of you is the time to fatality. So, in the Western world, where they have access to good anaphylaxis registry and there is a good amount of data on fatal anaphylaxis, what they have found is that the time to fatality can be really quite small. Okay, for instance, if let's say for a drug induced anaphylaxis, so if it is an IV drug that is causing the anaphylaxis, and if you look at the fatalities that are involved, the time to fatality can be as little as 5 minutes. Okay, so this just tells us that we don't get much time. Anaphylaxis may not give us much time. So you have to recognize it promptly and treat it. And if it was to be, let's say, insect venom, which is one of the other, important cause of fatal anaphylaxis, it can be as little as 15 minutes, 15 minutes, which is quite small because often it's happening outside. Outdoors, and by the time the patient can get to a medical facility, 15 minutes may be long past. So it's really important we know how to manage this, and it's important that the patients also know how to manage it. For example, in food-induced anaphylaxis, the time to fatality is roughly around 30 minutes in fatal anaphylaxis. So again, that doesn't give us much time to handle this. So that is why we also stress that not only us knowing how to manage it is important, but the patient and the family need to know how to manage the anaphylaxis. Okay, and as I said, the situation in India is very difficult because we have lots of shortcomings, and we don't have enough data. We don't have access to adrenaline autoinjectors, etc. I'll go through some of those aspects. Okay, so what I'm now going to do is take you through the see some of the guidelines. Primarily, I'll focus on the World Allergy Organization guidelines, but there are a few more updates which I will cover. Okay, and then a little bit about classification, the trends, of course, the treatment, most importantly, and the risk factors. How do we identify the patient who's at a big risk of dying of anaphylaxis? And a little bit about the biomarkers and newer adrenaline devices also. Okay, so just to highlight that, deaths due to anaphylaxis, unfortunately, for many reasons, keep happening, and they keep getting reported all over the world. And here is one report from India with the drug-induced anaphylaxis. But we also know that it is not well recognized and often underreported. So here's a case report of lignocaine causing anaphylaxis. And then here is an unintended or an accidental ingestion of crab in a patient known to have allergy, and they died when they ate some street food. And here is a patient in Kerala who died after eating, wheat product paratha, which she was known to be allergic to, but an alternative practitioner claimed that she had outgrown her allergy, so she ate it and she died. And here's again a patient who died of accidental exposure to prawn, knowing that she was allergic, but in her PG she ate it inadvertently and she died. So there are several reports like this, but we don't know the true incidence. So the definition of anaphylaxis. So this is the World Allergy Organization definition. And it essentially says that anaphylaxis is a serious systemic hypersensitivity reaction that is usually rapid in onset and may result in death. Severe anaphylaxis is characterized by potentially life-threatening compromise in airway breathing and/or circulation. And the other important thing is that it may occur without the typical skin features that we all very well know and recognize, like urticaria, angioedema, etc., or even circulatory shock being present. Okay, so you can have just a respiratory manifestation of anaphylaxis. So it's important that we realize this and we are aware about this. Clinical features, I think all of you know, but essentially you can have urticaria, angioedema, laryngeal edema, pharyngeal edema. You can even have very severe GI symptoms as a part of anaphylaxis. So I don't mean mild, pain, abdomen or vomiting. This is like an intractable vomiting or a very severe abdominal pain mimicking a surgical abdomen. And then you can have wheezing because of lower airway involvement along with shortness of breath. And you can have the cardiovascular manifestations of low BP, like altered sensorium collapse and unconsciousness, etc. Okay, so this we all are aware of. And another feature is this peculiar feeling of impending doom. So because this phenomenon can be so quick and so rapid and so severe, patients often feel that something horrible is going to happen to them. And often people will describe that I felt I was going to die. Even children are able to describe that to us, actually. Okay. So regarding the criteria for diagnosis, so this is the World Allergy Organization criteria, which is kind of very widely used. But then there is a bit of a modification, which also I will go through. So if you just follow the screen, you will see at the top, you have anaphylaxis is highly likely when any one of the following two criteria are fulfilled. Okay, so there are two criteria that are here. Criteria number 1, which I have circled in red, and criteria number 2, again circled in red. So criteria number 1 is acute onset of an illness in minutes to several hours with simultaneous involvement of the skin, mucosal tissue, or both. Okay, so there is a very prominent cutaneous or mucosal manifestation here, along with at least one of the following. So what is one of the following? It can be respiratory compromise, which is marked as A. You can have cardiovascular compromise, which is marked as B, reduced BP or associated symptoms. And you can have severe GI symptoms. Okay, so if you have the cutaneous manifestation and at least one of these, you can classify this as anaphylaxis or diagnose it as anaphylaxis. If you look at criteria number 2, you have acute onset of hypotension or bronchospasm or laryngeal involvement, okay, after exposure to a known or highly probable allergen for that patient. Okay, so here you are allowed to have only one system involvement, either upper airway, lower airway, or you can have cardiovascular involvement after exposure to a known or highly probable allergen. For example, I give the patient an IV drug and immediately the patient gets laryngeal edema. That has to be diagnosed as anaphylaxis and treated as such. Okay, so these are the two main diagnostic criteria. And here, if you see in number 2, you have even in the absence of typical skin involvement. So that is a very important aspect to notice. So often, if you have a very rapid, um, uh, symptom of anaphylaxis, you may not even produce the skin manifestation. And why is this emphasized so much? It is simply because this situation where you don't have skin manifestation is higher representation in fatal anaphylaxis. So hence the emphasis is being given to this because it's poorly recognized if there are no skin manifestations. Okay, so this is a pictographic representation which some people find easier to understand. So on the left you have criteria number 1 and on the right you have criteria number 2. And as I said, the criteria number 1 is acute onset of illness with the cutaneous or mucosal manifestations. So you can see this patient with a lot of hives here. And then you got to have airway and breathing, circulatory or GI compromise. Okay. And then on the right, you have criteria number 2, where you have acute onset of either cardiovascular or respiratory manifestation, even in the absence of typical skin involvement. Okay, so actually this WAO criteria is quite straightforward. And yeah, as I said, the cutaneous manifestation, lack of, is very common in fatal anaphylaxis. Okay, and in fact, we even need to remember that you may not have any cardiovascular shock also. So certainly when I did my MBBS, we would learn of anaphylaxis as anaphylactic shock, whereas you may not really have cardiovascular shock in anaphylaxis, and it can still be anaphylaxis and it can still be fatal, and hence it's important to recognize. Okay, and also to highlight that in up to 35% of the cases in some studies, it has been shown that the cause is idiopathic, no identifiable triggers. That's a very high percentage. But in some other studies, it is lower, but it can be quite high too, idiopathic. I'll show you some data as we go. So differentials. So differentials can be an acute asthma attack. It's a very common mimic actually, and often anaphylaxis is misdiagnosed as an acute, severe life or a life-threatening exacerbation of asthma. And syncope is again a common kind of a diagnostic dilemma for us. Like for example, if we are giving some patient an injection of a drug, or we are doing an allergy test, or we are giving them immunotherapy, subcutaneous, etc. The patient may faint because of the pain or fear, and then it can be confusing because you're potentially giving them an allergen. You're exposing them to an allergen. So it can be a diagnostic dilemma for us. Even anxiety and panic attacks have been known to mimic. Okay, and of course there are so many more, but by far, this is quite common what we see in terms of acute asthma, syncope, and panic attack. Okay. Now, I mentioned that the WHO guideline for the diagnosis, the criteria for the diagnosis is widely followed, but and that was in 2020. In 2024, there was, there is something called GALEN, which is a global allergy asthma network of various allergy professionals. And here, what they did is they came to a consensus report. I'm sorry. So here, if you see, they have slightly revised the diagnostic criteria. I'll go through that, and also have highlighted some of the symptoms and the treatment. And most of this I will be covering later also. But just to highlight the diagnostic criteria, so I showed you 2 diagnostic criteria in the WHO. Here they have divided into 3 criteria. Okay, and this is mainly to do with potential allergen exposure. So for example, if you see criteria number 1 at the top, you will see no known allergen exposure. So there is no obvious allergen exposure, but the patient presents with obvious hives, let's say, and also has respiratory or cardiovascular involvement. You will still treat it as an anaphylaxis. And then you have criteria number 2. Here, there is a likely allergen exposure. You may or may not be very sure, but the patient just needs to have 2 of these. So one is the skin mucosal or respiratory, cardiovascular, and severe GI. So if they have two of these, you can diagnose as anaphylaxis and treat as such, okay? And then the criteria number 3 is pretty much like the criteria number 2 of the WAO criteria, where you have a definite known allergen exposure or a highly likely allergen exposure, and you have either respiratory or cardiovascular manifestation, okay? So this one has been segregated basically depending on the likelihood of allergen exposure so that we do not miss any diagnosis or we don't overdiagnose, okay? So causes of anaphylaxis, I think all of you are familiar. It's essentially food, drugs, venom, and others. Food, the common ones are milk, egg, peanut, certainly in children. These are very common. In adults, we see more of wheat, sesame, fish, shellfish, seafood is fairly common. And in India, we also see lentils, etc. Okay, and drugs, you all are familiar that antibiotics, especially the penicillin group and cephalosporins, NSAIDs, these are all very common causes of anaphylaxis. And insect venom, wasp, bee, fire ant, not very common, but very much an important cause of fatal anaphylaxis. And others. So exercise, I want to emphasize on exercise. Exercise-induced anaphylaxis is a known entity, and it is one of probably the most poorly recognized entities. And vaccines, immunotherapy, blood products, latex are all causes of anaphylaxis. Types of anaphylaxis, this is again a bit of theory, but as immunologists, you all know that a lot of the anaphylaxis we see is IgE mediated because of allergy. Okay, so IgE dependent, but you also have a lot of IgE independent anaphylaxis where you just have a catastrophic mast cell degranulation or release of mediators without the involvement of IgE. For instance, if you look at the bottom, you will see exercise as one of them, okay? And you will also see alcohol and a few medications are involved in a non-IgE mediated mechanism, okay? And of course, there is the idiopathic category. Now, we all, a few weeks ago, we had a very nice talk about mast cell disorders, mast cell activation, etc. So that also, can happen without any apparent trigger. So that would kind of be classified under idiopathic anaphylaxis because it is very much a mimic and you treat it as such. You still treat it like anaphylaxis. Also, I want to highlight the factors and cofactors amplifying anaphylaxis. So this is again very crucial because there are so many factors that the patient is undergoing which actually makes things a lot worse for the patient. For example, infants are usually a little more susceptible. Pregnancy and postpartum period, the elderly are also susceptible for various factors. For example, elderly, they have a lot of comorbidities like cardiovascular or respiratory disorders. They may be on several medicines, polypharmacy sometimes. So all of these may kind of aggravate the symptoms of anaphylaxis and make them more vulnerable. And of course, if they are using concomitant medications like beta blockers or ACE inhibitors, if they're on alcohol, or if they're on certain psychiatric medications or recreational drugs, and of course, if they have concomitant diseases like asthma. So I'll show you some data later. Asthma always comes up as a risk factor, particularly for fatal anaphylaxis and severe or near fatal anaphylaxis. Cardiovascular diseases, because that will reduce your reserve to compensate. And of course, mastocytosis and clonal mast cell disorders, even allergic rhinitis and eczema, because it's a state of inflammation. Even this can be a cofactor amplifying anaphylaxis, okay? And exercise, I told you that exercise itself can cause anaphylaxis, but it is also a very important cofactor. Acute infection, even emotional stress, disruption of routine, jet lag, etc., premenstrual status, all of these are cofactors. So it's important to recognize this because the patient is more vulnerable during these, when all of this is there. Okay. Also, I told you about idiopathic anaphylaxis. I just want to highlight this very peculiar allergy called alpha-gal allergy, which was recognized a few years ago. So all allergens generally that we know of are proteins. Whereas this is a peculiar one in that it is a carbohydrate, okay? So alpha-gal is an allergy to a carbohydrate, which is called galactose alpha-1,3 galactose. It is found in mammalian meat, but it is not there in human flesh. So we, can react to, we can actually, mount an allergic response to this, okay? And like, for example, pork, lamb, beef, etc. can contain it. And the other interesting fact is most of the anaphylaxis or allergic manifestations to allergens happen within minutes to couple of hours at the max, whereas this one can be quite delayed up to 8 hours, which means that the recognition can be quite difficult because we always look for temporal relationship. You've heard, so many lectures on allergy. You even heard our Dr. PKV sir talking about, the basics of allergy and looking for temporal relationships. This is a very confusing one because it's not immediate. But there is a specific IgE test which is available, and you can actually test for it. And interestingly, the sensitization occurs through a tick bite. Okay, and even the the oncology drug cetuximab contains alpha gal, so some of the patients may react to it. So it's important to know about it. And this particular allergy used to be classified as idiopathic previously, whereas now this is one less thing, one more thing that we are aware about. So one less cause of idiopathic. Okay, so a quick word about grading of anaphylaxis. So a lot of work has gone into grading because in studies when we are reporting or when we are reporting anaphylaxis, it's important to grade it so that we know the severity. For instance, if I'm studying an immunotherapy medication and I want to publish it, so I need to know the kind of reactions that the patient experienced, and there should be a universal language where everybody recognizes that if I say there was a grade 4 anaphylaxis, then everybody knows what exactly was involved and how severe the reaction was. So that is why grading becomes important. Okay, so this is just to highlight what I have said so far, that when a patient gets an anaphylaxis or a severe reaction, it is not just one thing contributing. It is usually a series of different things that come together to make this host particularly vulnerable. Okay, and similarly, there can be a lot of protective factors. For example, if you look at the top part of this diagram, which I'm pointing, so you have the allergen presentation, of course, but then you also have the host immune response. You have the host behavior. You have the burden of allergic diseases. So, for example, if the allergic diseases like asthma, allergic rhinitis are very well controlled, okay, the burden of allergic disease is lesser. If the patient is on, appropriate medications to treat this, like for example, his asthma medications, other host factors like patient is very well otherwise without any cardiovascular morbidity, and his ability to compensate is very very good, and the treatment that he gets is prompt, then he might end up just having a mild reaction. Okay. Whereas if you look at the bottom, if a lot of host factors come together, where the patient has other morbidities, his asthma is uncontrolled, he has cardiovascular morbidities, he's on various medications, probably under other recreational drugs or alcohol, etc. So many things will come together, and which means that he ends up having a severe reaction. Okay. And it's important to understand this concept so that we maintain our patients to the best of our ability, in the best of condition that we can get them in, so that if they are exposed to their allergen unintentionally, they end up getting a mild reaction. And that responsibility is ours. Of course, there will be non-modifiable factors, but whatever is modifiable, we've got to do it. Right. So, little bit about global trends of in anaphylaxis and clinical implications. So, as I said, because in India we don't have our own data, so I'm kind of showing you some of the Western data just for us to get ideas about patterns. Okay. So, in this particular epidemiological data, what we found is that it's interesting, and this is a recent kind of 5 years ago publication. It shows that there is no kind of increase in the overall mortality when it comes to anaphylaxis, although there is an increase in all-cause anaphylaxis. Okay, so number of cases of anaphylaxis are rising, but the mortality is not. But in some countries, they have realized that drug-induced fatalities are rising. Okay, so if they were to put an incidence, they have found that around, let's say, up to 1% of all hospitalizations due to anaphylaxis can be fatal. Okay. Now, this is not all anaphylaxis because not everybody with anaphylaxis may end up getting hospitalized. So this is the hospitalization due to anaphylaxis. Okay. And they have looked at data from fatality registers. So I told you about how a lot of countries maintain these good registers. And what they have found in terms of modifiable risk factor is delayed adrenaline administration in terms of treatment. So that is a risk factor for fatality. If you do not treat your patient on time, the patient will die, obviously. And change in posture. So I will highlight to you that when I talk about treatment, that it's so crucial that the patient with anaphylaxis is not made to stand or sit suddenly. Because when you have anaphylaxis, particularly with cardiovascular involvement, you are in a state of profound vasodilatation, and which also means venodilatation, which means that if you stand up, you lose the venous return to the heart, and that can be catastrophic for the patient. So you have, sudden cardiac arrest because of that. And the population at risk have found to be elderly and those on multiple medications. Food is the most common trigger for anaphylaxis, but it is not the most common cause of fatality. So that's the what is represented in most of the data. Insect allergy is not that common, but it is overrepresented in fatality. So we are very cautious when we treat patients with insect allergy. Okay. Now this is just an interesting data about food anaphylaxis in the UK, where they have looked at 20 years of analysis of their national data. That's very robust data of over 20 years, which they have analyzed. And they had a total of more than 1 lakh cases of anaphylaxis admissions, out of which 30% were due to food. And again, what they found is food anaphylaxis admissions have increased quite a lot, almost kind of fourfolds. And largest increase was in young children, which for us pediatricians is quite worrying. And what they found is 152 deaths they had from food-induced anaphylaxis of all ages, and out of which about half was from nuts, peanut or tree nut. That is why they are so scared of nut allergy. Fortunately in India, it is not yet that common, but we are all seeing more and more cases of nut allergy. So we have to be really cautious, and it's a big worry for us because of the kind of lack of systems in place in our country. So if nut allergy rises, it's going to be very difficult for us to manage these children. And the other thing that came out is that in school-age children, the most common cause of fatal anaphylaxis was cow's milk. This is school-age children. So all ages was nuts. If we look only at school-age children, it was cow's milk. And so overall, however, there was a reduction in case fatality, which is quite encouraging. Okay, this is just to show at the bottom of the graph, you'll see rise in food-induced anaphylaxis. You look at the rising graphs, but you will also see that the fatality has come down. Okay, so this is again to show you that in children, the breakup of food-induced anaphylaxis. So you will see how unknown or idiopathic constitutes 29%, and you will see this large blue bit, which is the milk. And if you look at adults, again, the orange part is unknown. We don't know the cause. And if you see the pink part, it is unidentified nut. And of course, you also have a lot of large representation with peanut and with tree nut also. And you will also see milk also is there, but smaller than in children. And of course, you have fish and crustaceans, etc. So this is the adult data. Okay. Now, again, I just want to show you a little bit about fatal and near fatal anaphylaxis data, just to highlight that in adults, the most common cause of fatality is drugs and insects. Okay. And also, if you just look at this graph here at the bottom, this is fatal reactions. And next to it, you'll find near fatal reactions. So if you see the breakup, food, drugs, and insect venom, just follow my pointer, you will see that food in adults is not that common. In children, it is more common. But in adults, you will see the drugs is quite a large cause of fatal reactions, as is insect venom. And that is kind of represented in near fatal also. Okay. Now, management. So that is the most important aspect I want to highlight. Management, as you all know, the first part is recognition. You need to diagnose it. And that, I think, having gone through this, all this information, I think you are hopefully fairly familiar with that. And the mainstay of treatment is adrenaline. 10 micrograms per kilogram given as early as possible. So it works out to 0.01 milligrams per kilogram, and the maximum dose in an adult we would give is 0.5 milligram. In children, sometimes we would work with the body weight, but in adults, we would give them 0.5 milligrams, which becomes equivalent to 0.5 ml of 1 in 1,000 adrenaline. And of 1 milligram in 1 ml concentration. That's the vials that we generally use. And it is given intramuscular to the anterolateral aspect of the mid-thigh, which is a large muscle, very well vascularized striated muscle, and hence that is the location of choice. Okay, so in the past, people would use subcutaneous route, but that is not to be done any longer because it takes much longer for absorption. And this is just for ease of recognition. So in a young infant, we would work by milligrams per kg body weight, 0.01 milligrams. And in young children, less than 5, we would just give them 0.15 milligram or 0.15 ml. In older children, up to 12 years, we would give them 0.3 milligrams. And anybody older than 12, like teenagers and adults, we would give them 0.5 milligrams of adrenaline. So this is probably the most important thing for all of us to remember. And this just highlights the other management pathway. So basically, one is that because anaphylaxis is not something that most of us will see every day, you've got to know the protocol very well, and you should have rehearsed it, like in an emergency room, like a simulation training kind of a thing. And the other thing you would do is remove the trigger. For example, if a patient is getting an IV drug, you would first stop the drug if you suspect that the patient is reacting. And then you would do many things simultaneously. You would assess ABC, you would call for help, you would you would make the patient lie down, of course. And if they have breathing difficulty, you would prop them up so that they can breathe easily. You would give them injection adrenaline at the doses that I have just discussed. And it is good practice to elevate the patient's lower extremities to increase the venous return and give them oxygen if they have any kind of respiratory symptoms. Give them IV fluid bolus if required. And in the unfortunate event of cardiac arrest, you would follow the cardiac arrest algorithm. In which case, if the patient is in cardiac arrest, we will give them the cardiac arrest protocol of IV adrenaline. Or if IV access is difficult or not available, then we would go for intraosseous. That is the only place where IV adrenaline is indicated in the cardiac arrest algorithm. Otherwise, it is intramuscular adrenaline. And then you keep reassessing. That is the protocol for management. Okay. Just a quick word about the additional acute management. So you all know that most patients with anaphylaxis who end up in the hospital will invariably get, injection hydrocortisone and injection Avil. I must admit that it is getting better now. So most of the times when I see patients with anaphylaxis later on in my outpatients, I am seeing more and more correct management being done. Whereas in the past, I've been doing this lecture for more than a decade now, and in the past, when I would talk to people or when I would see the patients, I would see that adrenaline was not administered, but it is much better now. And so also additional management, we can use short-acting beta agonist in the form of a nebulizer or an inhaler if the patient has bronchoconstriction. But all of this is in addition to the basic management, including the intramuscular adrenaline. If there is upper airway obstruction, we can use nebulized epinephrine. And first-generation antihistamines have a very limited role. They only help with the cutaneous symptoms and nothing else, and nobody is going to die of their cutaneous symptoms. So, and also, rapid administration of, let's say, Avil can itself trigger hypotension. So, you're actually harming the patient by giving this to them in the acute phase. We can always give them oral antihistamine once the patient is stable. Okay. Glucocorticoids are commonly used, but there's a bit of a controversy here. I have another slide on that. I'll come to that. So some patients on beta blockers may not respond promptly to adrenaline. Most will, some may not. In which case, we would give them parenteral glucagon. Okay, so these are some of the additional managements. It is also recommended that serum tryptase level is done about an hour or two after the symptom onset, and also at 24 hours after resolution of the symptoms to get a baseline serum tryptase. And I'll talk a little bit about that also. And observe for biphasic reaction. Always have a written discharge plan given when the patient is ready for discharge, which is generally at least 12 hours later, if not 24 hours after the event. Okay. And an appropriate follow-up plan and referral for further investigation and education and management, most of which should have been done while the patient is with you in the acute phase. Okay. This is just a little anaphylaxis kit that I feel that every doctor practicing anywhere or going anywhere should carry with them. It will contain a few vials of adrenaline, which is in date. a few small syringes so that you can actually draw up the precise amount, because you may have to draw very small amounts, 0.15 ml, for instance, or 0.3 ml. It's useful to have a 1 ml syringe, but make sure you have an appropriately sized needle, like a 1 or 1.5 inch needle, so that we can give the intramuscular injection appropriately. If it's a short needle, you might end up giving it subcutaneously, which means the patient will not respond well. This is just to show that there are many refractory anaphylaxis algorithms. A lot of them are in the anesthetic guidelines, because often when there is refractory anaphylaxis, we certainly would have the ICU team or the anesthetic team involved. And they involve usually giving IV adrenaline as an infusion, not as a bolus, as an infusion. And, this just highlights that. So in the interest of time, I'm not covering this part. But we can discuss that when we meet in person. So this is about refractory anaphylaxis. And by the way, refractory anaphylaxis is when the patient has not responded to two appropriately given doses of intramuscular adrenaline. That is what constitutes a definition of refractory anaphylaxis. This is an example of an anaphylaxis action plan. Okay, so all our patients whom we diagnose with anaphylaxis, particularly with food or let's say insect venom, where they are vulnerable out in the community, we always send them home with this kind of an action plan, which tells anybody, for example, the school that is looking after the child, what constitutes an anaphylaxis, what is a milder reaction where they can get away with giving an antihistamine, when do they need to give adrenaline, how to give the adrenaline, and other simple things to do. For example, you will see here in the figure, make them lie down. Don't make them stand up. Even that is there in the action plan. So this becomes really crucial when patients are out there and somebody else needs to treat them other than the doctor or the family. Okay. Long-term management is essentially what we have just discussed. Access to an adrenaline auto-injector, particularly in food allergy, exercise-induced, or let's say in insect venom anaphylaxis, is absolutely crucial. We give them a plan. Sometimes we give them an identification bracelet, especially in young children who may not be verbal, so that everybody knows that this patient is allergic to, for instance, a particular food like milk or egg. And then, of course, you would investigate them when they are better. So if we are doing skin prick test, we would not do it until at least 4 to 6 weeks after the episode. And of course, we would also try to, in certain cases, very few cases, to be honest, look for desensitization or immunotherapy, etc. Like, for example, insect venom anaphylaxis, very amenable to immunotherapy. We don't have the best products yet in India, but in the West, it is standard practice, and they do very, very well with insect venom immunotherapy. Okay. Now, this is just to highlight the indicators of adrenaline auto-injectors. So certainly systemic reaction to food allergen is one of the most common indications. Idiopathic anaphylaxis, definitely we send the patient home with access to adrenaline. Systemic allergic reactions to immunotherapy, for instance, venom allergy, patients with elevated baseline serum tryptase level also sometimes we would consider with history of anaphylaxis. Exercise-induced anaphylaxis, definitely. Cold-induced urticaria patients, if they are exposed to adequate amount of cold, they can actually get anaphylaxis. So this is another indication. Patients on omalizumab also, we would give them access to adrenaline, basically. This is to show you auto-injectors, which unfortunately are not widely available in our country, but would be really, really useful and a boon to our patients and life-saving. And we have other ways of, giving patients access to adrenaline, like we make up little syringes pre-filled with adrenaline, and we mark the date. Generally, we give it for, depending on the situation, 1 month to 3 months, they can use it for, provided they have maintained it correctly. Adrenaline is light sensitive, so it has to be protected from light. But auto-injectors are very, very easy to do. And here you can see the child themselves administering the auto-injector. It's that easy. So this is again about refractory anaphylaxis. Just to show you that, there are many guidelines out there, and essentially it involves, actually the previous slide, going for the adequate IV infusion of the adrenaline, followed by other vasopressors. And then in the worst case scenario, if the patient isn't responding to anything, you may have to, go for ECMO to save the patient's life. So resuscitation, just a couple of important things for us as, non-intensivists. So the adrenaline route. So often I get asked, why not IV? If there is an IV line in place in the hospital, for instance, all guidelines discourage use of IV route because, except probably in the perioperative setting, when the patient is monitored by the anesthetic team, etc., they can directly go for an IV infusion. Even then, most of the guidelines will say you start with an IM adrenaline and then you move on to the IV because it takes time to make up the IV infusion. Even if it's a couple of minutes, you don't want to waste that time. Okay. And so it is intramuscular route which is recommended. The other thing to mention is people have looked at adverse events because of IV administration of adrenaline, and they have realized that there is a higher incidence of overdose. It's very difficult to overdose with the intramuscular, to be honest, okay? And also a higher incidence of cardiovascular events compared with IM administration, including severe hypertension, myocardial infarction, and stroke when we administer adrenaline by the IV route. Hence, it is discouraged. And IM works beautifully, I can assure you. It works very, very well if you do it correctly. So please remember intramuscular adrenaline. And as I said, if the patient is in cardiac arrest, we will go for the cardiac arrest protocol with the IV bolus. That is the only situation where we will go for IV bolus. Okay. And so subsequent doses of adrenaline, once I have given one dose, only 10% of the reactions may not respond. Most of them will actually respond. 90% will respond to the first dose. There will be a proportion who don't, in which case 5 minutes later, we are allowed to repeat a second dose or even sooner if it's severe enough. Okay. And then 98% of the patients will respond to one or two further doses of intramuscular adrenaline. There will be 1% or 2% of the patients where you will have to go to the refractory anaphylaxis protocol. Okay. Role of antihistamines, I have also already told you that it's a very limited role. You can give oral antihistamine later. Try to not use intravenous first generation antihistamine. Okay. Role of glucocorticoids, a little bit controversial, and actually there is limited evidence for routine use. Previously, we would think that it actually prevents biphasic reaction and shortens the duration of anaphylaxis, but recent studies have shown otherwise. And in fact, in this guideline I was talking about, they have actually suggested against the routine use of corticosteroids to treat anaphylaxis. Many countries, including UK, have gone away from using corticosteroids as a part of their anaphylaxis management. Okay, so they say that we suggest corticoids may be used as a third line intervention to treat underlying asthma or if there is a shock, and they say that the evidence is weak. The recommendation is weak with low certainty evidence. And that's the reality of steroids. But unfortunately, a lot of the times, as I was mentioning, our patients just get steroids. And so that's really not to be done. And emerging evidence that routine use of corticosteroids for anaphylaxis may actually be harmful and associated with increased morbidity, even after correcting for confounding by the indications. So, this is a space to watch. In Canada, for example, they have found that, patients who actually received steroid did worse than patients who did not. So, we've got to watch out for this. So, be cautious about use of steroids, essentially, okay? This is just to highlight the observation time for anaphylaxis. So, remember I mentioned that do not discharge the patient for at least 12 hours, preferably 24 hours if it was a severe episode. And this just highlights that. So, the Western, the system is such that they want to get patients discharged as soon as possible. So they try to minimize the observation time. But in our country, where we have limited access to adrenaline, our patients may not have the necessary, ambulance access or access to urgent medical care. I think we have to be even more cautious. This I will highlight because you're all practicing immunologists, so you would be more interested in this also. So if you see, so this is the diagnostic evaluation of a patient with anaphylaxis. So if you can just follow my cursor, see if you get a likely trigger, as you can see here, if it's yes, you just do the standard management, okay? Now, where you do not get a likely trigger, you measure their baseline serum tryptase, definitely. And if the tryptase is elevated, baseline tryptase is elevated, then you will work up for mastocytosis, etc. Okay. And also, if the baseline tryptase is more than 8 nanograms per ml, you've got to think about hereditary alpha tryptosemia, which is a autosomal dominant condition where patients have an elevated level, baseline level of serum tryptase, especially the alpha part. Okay. But what if the serum tryptase is not elevated? So then you would do something called the RIMA score. I'll talk about this. So this is in Spanish. The expansion is in Spanish, but I'll tell you about the score. If the RIMA score is high, you would work up like for, you would work up for mastocytosis, etc. But if the RIMA score is not high, you would repeat that tryptase during the acute event, and then you would see whether it is elevated, in which case you think of mast cell activation syndrome, etc. We've heard a very nice talk on that. And if it is not elevated even during an acute event, you got to think of other mimics. It's probably not anaphylaxis. Okay. Now, what is this RIMA score? So this is actually the NIH idiopathic clonal anaphylaxis score, where we are looking for evidence of clonal mast cell disorders. So you have on your left this RIMA score, which, as I said, is a Spanish expansion, and you have the NICAS score. So the RIMA score is essentially a clinical score along with baseline tryptase. Okay. So again, in the interest of time, I'm not going through all of this, but the NICAS score is interesting because it also has the genetic test. A positive genetic test simply means a very, very high likelihood that this is a clonal disorder of mast cells, basically. Okay. So again, just to highlight this again, I won't go through, but I have actually shared this document, and Dr. Kunal has sent it in the group. So do go through this. Very interesting. Few things I will highlight is that the measurement of baseline serum tryptase, which I have already mentioned, we do it if there is severe recurrent or idiopathic anaphylaxis, if there is Hymenoptera venom anaphylaxis, because these patients generally are at a higher risk of having higher baseline serum tryptase. Suspected mastocytosis, of course. Okay. And in the last few years, we have learned about this new condition called hereditary alpha tryptosemia, where patients have a elevated baseline serum tryptase level. I already mentioned about alpha-gal allergy. Biphasic reactions, just to mention that around 7% of all patients who have anaphylaxis will end up having a biphasic reaction. That means all symptoms subside, and then around 10 hours to 11 hours later, which is the median duration, the patient will again have all symptoms of anaphylaxis. Okay. And what it is said is that the more severe their initial symptom, the higher the risk of biphasic anaphylaxis. Adrenaline delayed, higher the risk of biphasic anaphylaxis. Use of more than one dose of adrenaline, which simply means the reaction would have been more severe or persistent, higher risk of biphasic reaction. Okay. So just to be aware. Okay. Identifying patients at a higher risk of anaphylaxis, I just want to highlight that serum tryptase is what we now use as a surrogate marker for anaphylaxis. It has a sensitivity of about, let's say, 70%. May not be very, very specific because of the reasons we have just discussed, but people are looking for other biomarkers. For example, platelet activating factor, kinase, carboxypeptidase, prostaglandin F2, etc. Okay, so a lot of them are showing, a lot of promise, but they're all still under investigation. Okay, so maybe in a few years' time, we'll have something better than mast cell tryptase. Again, this I will discuss when I see you in person because it's a little complex. I need some time to explain, but I just want you to know that there are criteria for measuring the mast cell tryptase. So as I said, we would measure it 1 hour later, and then we get a baseline 24 hours after symptom resolution, or even later, we can get a baseline. And then this is the formula to actually calculate whether this is significant rise in the acute phase. Okay. So there is actually a calculator that you can use in the NIH website where you enter the baseline tryptase, you enter their acute value, and you can actually see in the graph whether it is a significant rise and whether this is a good predictor for diagnosis of anaphylaxis. Okay. Now, genetics of anaphylaxis are interesting. So a lot of work being done. And I just want to point out that there is an entity called wheat-dependent exercise-induced anaphylaxis where only exercise patient does not react. Only wheat eating, no problem. But if these two come together, so I eat wheat and then I exercise, patient can have quite a severe anaphylaxis, often underdiagnosed because of the complexity involved in the diagnosis. There is a genetic basis to this. There is an allele identified, HLA allele. And then the other thing is, you all know that systemic mastocytosis also, there are mutations in the c-KIT where they are, which is now known. So hereditary alpha-tryptosemia, there is an autosomal dominant genetic trait, and there is an gene identified for that. Okay, so as we know more and more, I think the future looks promising in terms of identifying the high-risk population. Yeah, so as I said, the hereditary alpha-tryptosemia is definitely reported to be higher in individuals with mast cell-associated disorders, including anaphylaxis. Okay, role of component resolved diagnosis. We are going to be doing this in very much detail when we meet in person. But for example, this component in the peanut protein, ARAH2, is identified as a marker for severe anaphylaxis and peanut allergy. So we sometimes do use this when there is a doubt. Okay. Again, in the interest of time, I'm going to skip some of this and just go to my conclusion. Again, I mentioned about risk factors for food anaphylaxis. Asthma is always highlighted. Peanut as a culprit food, we are very scared of. And unfortunately now, cow's milk anaphylaxis is rising. Fatality from cow's milk anaphylaxis is also rising, which is quite worrying, particularly in young children. Okay. And the other thing I want to highlight is risk factor for near fatal anaphylaxis. The place where it occurs is home. 45% happens at home, which is really worrying, isn't it? So yeah, just to mention that omalizumab, which is anti-IgE, biological, is approved for management of multiple food allergy, particularly those prone to anaphylaxis. FDA has approved it. And so that's that. There is now not only injectable adrenaline, there is intranasal adrenaline, which is now FDA approved. That's what it looks like. It's called Neffy. And there is studies ongoing for sublingual adrenaline also, which will be such a boon to our patients. Intranasal works beautifully, actually. There are some bodies who are not completely comfortable, but most of the world is approving intranasal. Okay. In India, there are efforts to develop our own indigenous auto-injector, and there is one already developed in ISC, but unfortunately, for various reasons, it is not progressing, not having this available for clinical use. And so a lot of challenges in India. I think you've kind of realized, as I have spoken, the many challenges. And my take-home messages are, please recognize anaphylaxis. Early intramuscular adrenaline, I can't emphasize enough. Recognize your patients at high risk, identify them, empower them, educate them, manage them appropriately, give them the action plans. Okay. And anaphylaxis preparedness in all settings. It doesn't give us time. If it's going to be severe, you've got to be able to manage it within the minute. There is no golden hour, there is golden minute here. Okay. And just to mention that this is an initiative that me and some of my colleagues has started. I'm a part of an organization called MedTrain, where we are involved in allergy education. So this is called a website called Anaphylaxis India, where doctors and patients can access a lot of education. There are important links to all the major guidelines that we as doctors need access to. We are also working on an incident reporting, which is voluntary, obviously, but it will be really nice to have our own data. So I will pass on the information once it's ready for use, and I would, like all of us to be involved. Okay. So thank you very much. I will stop my screen share now.
Thank you, madam, for that very elaborate discussion on anaphylaxis. I think this is an area in which a lot more sensitization is probably needed, because still there is a lot of hesitancy in using adrenaline, and of course the lack of availability of adrenaline auto-injector is a huge problem. Madam, is there any role for using, I think I've come across some data or some reports of using long-term corticosteroid, tapering dose of corticosteroids for recurrent anaphylaxis. Is that a practice that can be suggested, or is that in patients who have recurrent anaphylaxis? I've come across one of the reports that usage of steroids from a higher dose and tapering fast was supposedly effective in at least some patients. Do you have any take on that?
So, sir, yes, I agree that it is being commonly used, but from all the guidelines, so I showed you a lot of the many papers, all the recent guidelines, and in none of them recommend that, sir. And
For the
so,
not for the immediate use, but for recurrent anaphylaxis for
yes, sir.
prevention of
Yeah.
anaphylaxis.
Yeah. So
And that
now
used to be a
what
practice
is,
some time back.
yeah, no, sir. So as so from everything that I have been reading all these years, I don't think that is a standard recommendation. And in fact, now for food allergy, for example, recurrent people who are very vulnerable, there is omalizumab that we can use.
I think
So
we can use
that is.
omalizumab along with desensitization therapy.
Yes, so desensitization, of course, it depends on what the condition is. But
Right.
yes, there is food desensitization, which is now being practiced. So oral immunotherapy, sublingual immunotherapy for food also done has to be done very carefully by experienced practitioners. But peanut is immunotherapy is FDA approved, and a lot of practitioners are also doing for milk, egg, and other allergens, other nuts also. And of course, there is I was mentioning about insect venom immunotherapy, which works very well with the right products. So yeah, definitely, yeah. Actually, I just realized our Vedantan sir, Dr. Vedantan sir, is here.
Oh, thank you.
Good evening and namaste,
Can I
sir.
speak can I speak a few words?
Yes, sir.
Okay, thank
Yes.
you. First of all, I want to congratulate Dr. Nandana for wonderful presentation. She covered it very well, very comprehensive, very practical, lot of information here that we need to learn from this beautiful presentation. A
Thank
few
you.
comments. One, there is, you might have already mentioned it, but I joined a little late. There is no contraindication for the use of epinephrine, when you're treating anaphylaxis. People worry about, he has got arrhythmia, he has got some cardiac issue, has had some cardiac issues before. So never think about all that. Go ahead and give that epinephrine because what you're doing is trying to save somebody's life. Second one, is Nandana, you might have already mentioned, I'm not sure, is expired epinephrine is still good. So there is literature to support that even after 4 years, it retains 80% of the potency. So I don't know why EpiPen, which is made in the US, has an expiry date of 1 year. I don't understand that.
Yes, sir.
So
Yeah.
I don't not understand. To me, it looks like more like the people just want to sell a lot.
Yes.
Because what happens in the US or many other European countries, I'm sure, the school districts, I know that for sure, they order something like 400 to 500 EpiPens every year,
Yes.
depending on the size of the district. And hardly they use 10 of them,
Yes.
and then they throw the rest.
Yes.
Gross waste. I have collected some of it because of my
Yes.
connection with the school district,
Yes.
which we have kept in some of the offices. But there's a legal issue because of the
Yes.
expiry date that is put, which is
Absolutely.
unfortunate. So, but anyway, just wanted to share that. Again, I just want to mention about the last point you mentioned that you are collecting some information, which is a great idea because anaphylaxis is not a reportable condition. You don't have to report anyone.
Yes.
But that is the main reason why we do not have the data on how prevalent it is in India. We do not know.
Yes.
We see this issue quite often. We hear about people having anaphylaxis, but some people can cancel it off as heart attacks and all that is misdiagnosed and all that. But having a registry is very important. Having a registry. So since you have started this data collection, you might even think about how do you form a registry for anaphylaxis in India. So
Yes.
this is something that your group as MedTrain has taken that initiative of educating everybody in anaphylaxis. You might even look at that possibility. I again want to thank you for this excellent presentation, and thank you. I
Thank you
need
so
to.
much, sir. Yeah, thank you. And your comments about the adrenaline expiry, that is very unfortunate because it is so expensive. So we do get it here, as you know, but those few who can actually afford it, literally it expires every year. So after a while they stop buying it because it's so expensive. And
Exactly.
it's very unfortunate. But yes, there are actually studies, as sir rightly pointed out, where they have looked at expired adrenaline, for many years later and found it is still efficacious. So again, the message is by mistake, if your adrenaline has expired and you need to use it, use it. It might still save the patient's life. Don't
Exactly.
not use it. Yeah.
Yes. Thank you very much. Thank you.
Thank you, sir. Thank you.
Thank you so much, sir, for attending and those valuable inputs. There are a few questions that are there in the chat box, and any specific guidelines or protocols for biologic induced reactions and anaphylaxis, whether you'd give them steroids, antihistamines in addition to adrenaline, or in addition to stopping the drug in cases with mild reactions like mild itching, can we reintroduce or re-challenge the biologic?
Yeah, so essentially, the treatment protocol remains the same, irrespective of the cause. So that's the other thing to emphasize on. Okay, so it is still adrenaline, and yes, of course, in some cases you might want to give antihistamines later. But as I was mentioning earlier, see, that's not going to save anybody's life. Okay, so that is not our priority. Don't get distracted by wanting to give the antihistamine. You prioritize the adrenaline. Be very vigilant about monitoring because you may need a second dose of adrenaline and even a third. And in the meanwhile, you're also, if I have done this in the periphery, for example, in an outpatient or a clinic setup, I am more now focused on getting the adrenaline in and getting the patient to a safe place. So I would call an ambulance or I would make some arrangements to get this patient safely transported in an appropriate kind of a transport to a hospital, nearby hospital where they can get the advanced treatment. So, of course, I can give the antihistamine later. You wouldn't be very wrong in doing the steroid because it is still a part of many of the guidelines, but I just showed you how a lot of the organizations or some countries like UK are not giving the steroids as standard. So, and that would apply to biologicals also.
Yeah. So the basic context of, I think, ma'am's talk and what we wanted to convey through the talk on anaphylaxis is that habit of reflex avil and Dexona or avil hydrocot whenever you see someone with a possible severe allergic reaction, even if you don't name it anaphylaxis at that point of time. Remember that the drug of choice of the reflex reaction should be adrenaline, not avil or Dexona or hydrocot.
Absolutely.
So
Yeah,
that's there.
absolutely.
I have a few questions, ma'am. So any lab where we can test for hereditary alpha tryptophanemia because
Yeah. So, as far as I know, and in fact, you as immunologists probably know more about these some of the investigations. But as far as I know, in India, we can test for the total tryptase level. I am not aware where you can test separately for alpha or beta tryptase. Okay,
hmm,
and of course, there's a genetic test which is there, which is not a part of our routine practice, but certainly in research, and most of the data we have is from US where they have started identifying these patients. So we have Caucasian data. We do not even know our incidence, for example, in the kind of Asian population. We don't know. But in Caucasians, it is 1 in 20, it sounds very high.
yeah, no, because I had possibly two patients who were suspected of hereditary alpha tryptophanemia, and most of the labs that are doing the genetic tests here, including I think MedGenome, they said that they don't do the tests, the
Yes,
genetic mutation analysis here. They
correct.
do the tryptase level per se.
Correct. Absolutely. I think it's a matter of time. I think as more data emerges, like how we've had a rapid increase in the number of, genetic tests we are able to do now. I think it's a matter of time, but I think we need more data before that happens. Yeah.
Yeah.
Now,
Then
just
they,
a word on that. Actually, I think whole genome and whole exome analysis, I think some of the companies like Arkinos are offering at a much cheaper rate, equivalent to that of a genetic study. I think they're offering it around 10,000 per sample. So that would be a useful scenario in this for rather than going, even if the specific genetic testing is not available, we can probably try that.
Yeah, perhaps, sir. Yes. Okay.
then there are a few questions on um, uh, how common is anaphylaxis with blood products and corollary along with anti-snake venom also.
Yeah, so fortunately, not that common, and I don't think we know the exact incidence. At least I'm certainly not aware. You can correct me if one of you knows that. But it just you still have to be vigilant because it is a known cause, and that applies to any of the drugs contrast media, radioactive, when we do CT scans and MRIs, we are giving people contrast media. So that is also a known cause. It is not common, but it can happen. And these ones can be very rapid, very catastrophic, especially the, radio contrast media. So we have to be very careful. Blood also definitely can cause, and it will happen while the blood is being infused. So you have to be ready. So it just means that every treatment area in the hospital should have a crash cart readily accessible, which has all your emergency things which you can retrieve in a minute, because as I was saying, you may not get much time. Okay. Insect venom are reported. Insect venom anaphylaxis is definitely reported. And anti-snake venom, I'm sorry, anti-snake venom anaphylaxis definitely reported. Again, I don't know, I'm not aware of the specific incidents. But again, you treat it as you do the basics. And if you do the basics right, I can assure you the patient will be okay.
Yeah. I think emphasizing to the corporate hospitals also the importance of possibly an EpiPen in their emergency crash carts. We see there are stroke protocols coming and MI protocols coming that gain
Correct.
a lot of
Yeah. Yeah.
importance and limelight, but
Yes.
possibly,
Even if EpiPen is not there, you make
yeah,
sure you have a vial of adrenaline and the appropriate syringes. You can draw it. An experienced person can draw it in seconds.
a
So,
handmade EpiPen also is a good enough option if you have
yes,
it loaded in a pre-filled
loaded.
syringe
Yeah,
because,
and protected in a
yeah,
light protective case for an emergency. That is absolutely brilliant because you can give it within seconds. Yeah,
then there is,
and the what is the most rewarding is the kind of response you get. The patient within minutes is completely recovered. So, it's something that we all should be ready to do.
yeah. Do- Then there's a question on, do we repeat adrenaline if no response has been there? And how much time do we wait after the dose?
Yes, so it's actually about 5 minutes. So if there's no response, you can repeat it in 5 minutes. But that's not an absolute thing. So if you feel it's very severe and you find that the patient is deteriorating in front of you despite having given adrenaline intramuscular appropriately, it is okay to repeat a little bit earlier also. It's absolutely fine. No harm is done. Okay. And how often you repeat it? As often as necessary, because if the patient is deteriorating and not responding, then he's going to die. So until you get definitive help, you just go on repeating it. But the emphasis should be on getting definitive help, getting the patient to a place where they can do the intensive care that the patient needs.
Yeah, so if you see any of those anaphylaxis action plans that ma'am are talking about, that possibly you would have or your patients would need, the first, this thing is usually to call for help and then give
Yes.
anaphylaxis.
Call
Uh,
for help. Yeah. If you're in a periphery somewhere dealing with this, the first thing you would do is you or assistant shouts for an ambulance. And then, of course, you are doing everything else. So everything happens simultaneously and parallelly because you need help very quickly. Yeah. And sir has just shared an article. Thank you so much, sir. We'll definitely go through that.
yeah, because in a country like India where reporting is very bad, a lot of anaphylaxis is actually labeled as heart attack or sudden cardiac deaths, and you actually don't know. These
Correct.
are patients whose lives are much more easily savable as compared to the ones
Absolutely. I'm
without
sure we're missing a lot of the cases, and unexplained mortality may be happening and we don't realize.
a
Yeah.
lot of gym deaths might be food protein
Exercise
induced,
triggered
exercise
or
induced
food protein
anaphylaxis. Yeah.
induced. Absolutely. Yeah.
So
Yeah.
that's it. Thank you. I think we've
Thank you.
already overshooted about 15 minutes of the talk time, but this was a very interesting talk, ma'am. And thank you so much,
Thank you
both
so much.
Vishal sir and ma'am,
Thank you for
for
having
being
me.
present.
Thank you.
Yeah. See you next week.
Yeah. Thank you. Thank you, Dr. Vishwanath. Thank you.